Dr. Subhendu Boral will be speaking to us on managing suprachoroidal hemorrhage, a nightmare of every surgeon.
Very good afternoon. Yes. Thank you, AIOC, for giving me the opportunity to thank you. Today my topic is suprachoroidal hemorrhage. It is the 1 in 1 lakh situation for every ophthalmologist after doing any kind of intraocular surgery. So suprachoroidal hemorrhage is a rare condition defined as a collection of blood into the suprachoroidal space, which is actually virtually a very potential space containing only 0.1, only 10 microliter fluid, and its incidence varies after ocular surgery 0.04 to 1%. We know all the predisposing factors for development of this kind of suprachoroidal hemorrhage, especially it is arteriosclerosis that happens because the arterial wall becomes stiffer, and when there is any sign of sudden hypotony, intraoperative hypotony, that stretching of the blood vessels can cause a rupture and accumulation of blood into the suprachoroidal space. So this is the factor. So sudden hypotony can result in stretching and there is a rupture of vessel wall. So arteriosclerosis is the main predisposing factor. So the signs of expulsive hemorrhage always to be expulsive, before creating any kind of hypotony, or you have to anticipate the situation. So any bulging forwards of the iris diaphragm, vitreous starts prolapsing out, there is iris prolapse and prolapse of vitreous to the wounds, all are the anticipating signs of this expulsive hemorrhage. So primary management, it is obviously the tight closure of the incision. Posterior radial sclerotomy, anterior radial sclerotomy, the people are hardly doing it, but still it is described in the literature. The common indications are extreme pain, a persistent flat anterior chamber, uncontrolled elevated intraocular pressure, retinal detachment, central choroidal apposition, retinal vitreous incarceration, or inability to reposit the intraocular contents. All are the indication for drainage. For secondary management of the expulsive hemorrhage, early referral to the VR colleague for an anterior segment surgeon is essential. Post-operative, anytime you can do it up till 2 weeks. Ideal time for drainage is 7 to 14 days after primary surgery because of adequate clot lysis. So surgical management described earlier, it is a radial sclerotomy. With the help of spatula, you can just remove the blood clots from the suprachoroidal space. Even you can do it as a primary procedure or as a secondary procedure. Dr. Rosie T. et al., they have described an anterior chamber maintenance along with ACH drainage through the anteriorly placed 23-gauge trocar cannula. So our technique is doing vitrectomy, injecting PFCL. So PFCL push from inside and external passive drainage of blood through the non-valved cannula posteriorly placed. You can place it at a multiple position. So coming to the first case, it is sorry, it's not running. Yes, there is hyphema, ACIUL, and central choroidal apposition you can see. And while just introducing that all the ports, you have to be very sure that all the ports should be inside the vitreous cavity. And after clearing the vitreous cavity, you can see there is huge choroidal on the temporal side. So I have planned to do the choroidal drainage from the expulsive drainage from the choroidal side, from the nasal side here, and just removal of the trocar cannula and injecting the PFCL from inside. So internal passive push and external passive drainage of the blood is possible in a sutureless way. Ultimately, we have removed the PFCL and injected the silicone oil, 5,000 centistock oil. So postoperatively, you can see there is dramatic improvement in the vision, but still, as the IOP was not maintaining, we have not removed the oil. So this is another case where there was a two-quadrant expulsive hemorrhage in the OCT, in the USG, and the videos are not running here. Yes. So this patient, unfortunately, the video was not running. So this patient, the patient ultimately gained 6/9 vision after silicone removal and glued oil implantation, and you can see there is complete drainage of expulsive was possible. This is another case where there is hemorrhagic kissing choroidals and with total retinal detachment, where I have ensured that all the ports are inside the vitreous cavity, cannula tips, and I have done the vitrectomy and just see the stick leg breaks in the temporal side, supratemporal side, and after doing all the kinds of vitrectomy, I've just cauterized the breaks and then injected PFCL just overlying the disc. Now you can see the disc is here. Now inject the PFCL, and slowly the blood will be drained. The subretinal fluid will be drained from the external from the anteriorly placed breaks. And you can see that I'm just aspirating on the fluid, but you cannot judge the suprachoroidal elevation before doing this this step. Otherwise, you can see that you could have seen that the elevation of the suprachoroidals were not that much apart from this huge apposition of this retinal detachment. So after that, after the surgery, I have you can see there is absolutely there is no suprachoroidal dissolving too much, and postoperatively you can see the retina is attached nicely, although the vision improvement is not that great. This is another patient where 78 years old lady came with a history of attempted phaco. There was appositional choroid and a lot of residual lens matter, and we have placed the port and started the case. Yes, this is the last video. And but we have started the case with the AC maintainer, and after placing all the ports, I've started doing vitrectomy, and removal of all lens matter was done nicely. Then I place one trocar cannula complex into the suprachoroidal place and remove the trocar blade, and then raise the IOP little bit, like 50 to 60 millimeter mercury for a temporary moment, and then just you can see the dark colored suprachoroidal blood is coming out, and I'm doing gentle massage to the other area so that there is a complete drainage of suprachoroidal blood will be possible, and you can see the multiple trocar cannula guided drainage, posteriorly placed cannula guided drainage was possible in a very sutureless way. You can put the trocar cannula complex at any site depending on the ultrasonography elevation of the suprachoroidal area, and as well as the amount of blood that what you have seen intraoperatively. And finally, after it is not mandatory to remove the blood at a single go during your surgery, and after clearing all the vitreous, the macula is rightly, you can just see macula, and injected the PFCL, so the macula is more visible. And then again, I try to drain the blood a little bit more, and finally most of the macula is visible here, and then I removed, yes. Then I placed that 6 millimeter cannula, and then do fluid exchange, settling the retina, and finally removed the PFCL and injected silicone oil 5000 centi-stroke. So postoperatively patient gained after 3 weeks 4/60, and after 8 weeks 6/24. So better prognosis cases are always SCH involving 1 or 2 quadrants, and poor prognostic factors are presence of retinal detachment, retinal incarceration, kissing choroidals, all these factors. So these are the good prognosis cases. These are the bad prognosis cases. So sometimes you should not remove the oil. So no need to intervene in case of nasal SCH, localized 1 quadrant SCH. So we have published our case report here. Thank you.
Thank you, doctor. I think it was a very detailed presentation. So I think the take-home message is you got to wait for 15 days for the blood to liquefy.
Like at least 7 to 10 days, at least for the adequate clot lysis. That should to be confirmed by doing ultrasonography.
I was wondering how many maximum cannulas have you put? Because I saw like a pin cushion effect.
5, 6.
5, 6. But I think don't forget to, you can expose the sclera and do your routine sclerotomy, a large one, cut down also. That can also work. We don't necessarily have to do these multiple.
But you have to suture it. That is
you can do that. And sometimes the blood is liquefied. A single sclerotomy can drain the whole suprachoroidal space also if you make a large enough one. Thanks, doctor. Great presentation.
That you don't have to use a valve cannula into this.
Yeah, that's very important. It should be not unvalved.
I think the drainage is complete if we slit and